Thank you very much, Francois. Ladies and gentlemen, thank you very much for the opportunity for discussing fevers this morning. The cold feet doesn't refer to fevers and cold feet in septic shock. It refers to apprehension about the subject. In British English, cold feet means that we're worried about something. It refers to although the world has been working on this problem for over 100 years, there are still enormous gaps, confusion within the subject. I think a lot more needs to be done. And if I could mention that there'll be a symposium this afternoon in the Nightingale after lunch that will take a more global perspective of this subject. I will be centering on the Mekong river basin in mainland Southeast Asia. So we're based in the Lao PDR or Laos. That's will be the focus of the talk. That's a land area about that of the United Kingdom, but with 1/10 of the population, with severe poverty, overwhelmingly rural. Transportation access has increased a lot in the last 15 years, but there's still communities who live far away from the center. Has a difficult history, being caught up as a neutral country within the Vietnam War. And there's been very little evidence until recently to inform Lao health policy, with evidence used from adjoining Thailand and Vietnam and France, but with very little information from Lao to inform health policy. When we started working in Laos at the end of 1999, there was only really one accessible diagnostic service, and that was for malaria. I thought it would be interesting to focus on some of the issues that we've encountered during the work in rural Southeast Asia. The aspects in blue we'll talk about more during the rest of the talk. I think there's confusion about what we mean by non-malaria fever. And there are enormous gaps geographical gaps and time gaps in mainland Southeast Asia. There are inadequate diagnostics with lack of quality assurance and quality control. And I think most extraordinarily, very few of the university and institute-based studies of the causes of fever in mainland Southeast Asia and in Africa, which you'll hear more about this afternoon, have used the same or even similar inclusion criteria, diagnostic and outcome measures. And this makes it very hard to compare between countries and to understand how algorithms should differ by geography. And also, we don't really know how many pathogens that we might expect in different areas. Even simple things such as how many days after admission blood sample should we take a follow-up sample for serology? Some people say 14 days, some people say 28 days, but it seems to be not based, as far as I'm aware, on evidence. And it would seem strange if the antibody responses to different pathogens led to the same optimum sampling interval. But also much of the academic work that's been done has been relatively circumscribed. Many people in mainland Southeast Asia live beyond infectious disease surveillance, and we really do not know what diseases they're suffering from, what the impact is, and how to manage people with infections living in remote communities. So there's some confusion, I think, about what we mean by non-malaria fever. In some papers it's regarded as the causes of fever in a community without malaria. So that would be applicable, say, in Laos for people living in Vientiane, because there's no malaria transmission within the city. But other people seem to think it regarded as meaning the causes of fever in a community afflicted by malaria, but who have a negative malaria diagnostic test, of which for that use of the term there are many fewer data points. So I think both meanings are used at the moment. We started out in 2002 to try and understand what are the causes of haemoculture negative fever in Laos, starting out at Mahasot Hospital, the main primary tertiary hospital in Vientiane City. And we found a lot of what we call DRI, or doxycycline responsive illness. Looking at those who were blood culture negative, 1/3 of them had a disease that we would expect to respond to doxycycline, especially scrub typhus, leptospirosis, and murine typhus. The first patient with scrub typhus that we diagnosed is the lady on the left, sitting next to Dr. Ratanaporn Petsuvan, who's the late director of the microbiology lab at Mahasot Hospital. And below you see a child with the eschar on his scrotum of scrub typhus, but as you can see, that would be quite easy to miss. And it's often the textbooks say it's a pathognomonic sign of scrub typhus. I don't believe that's true, because it's very hard to distinguish the eschars of scrub typhus from some of the Rickettsial spotted fevers. We wrote this up in, I think, 2006 and said this was the first report of scrub typhus in Laos. We were wrong. A colleague found this French language report of a description from 1939 in a French army lieutenant who died of scrub typhus, interestingly with central nervous system involvement in 1938. So I think it's important that we don't forget our history. Then Professor Maifong Maisai, who's here, worked with us on a large project to try and understand the causes of non-malarial haemoculture negative fever in rural Laos. And this demonstrated again the importance of dengue, scrub typhus, influenza, Japanese encephalitis virus, and leptospirosis. I think the Japanese encephalitis virus is misnamed because most people who are infected with the virus, if they are symptomatic, do not have encephalitis, and many people have an uncomplicated fever. As you can see, the proportion of patients with community-acquired bacteremia was relatively infrequent. It's possible that that was related to the transport of blood cultures from rural Laos back to the capital Vientiane. And reading about this was rather amazed that we still don't really know the optimum transport conditions for blood cultures if they're not incubated immediately. There's some evidence, which is for me counterintuitive, that they should be kept at +4 and not at ambient temperature. And it does seem, I think, rather extraordinary that in 2017 we don't really know the optimum method of transporting blood cultures, which will be increasingly important with enhanced surveillance for antimicrobial resistance. So I feel in this subject there are many cans of worms, i.e. an expression in English that you think you have a nice box, a nice can, you open it and found lots of trouble within. Rickettsial diagnosis in Laurasia is increasingly, I think, confused and complicated. Antibody assays on admission have relatively low sensitivity and specificity. And different laboratories doing serology, usually immunofluorescence assays, have different cutoffs for what is positive and what is negative. But those cutoffs seem to be not evidence-based. And there are some rapid diagnostic tests now being developed for both scrub typhus and murine typhus. But there's the information that comes with them I find very troubling. At the bottom, the scan is of a leaflet for a scrub typhus, for a pan-Rickettsial IDT sold in Southeast Asia, whereas you can see they claim that the sensitivity and specificity for all Rickettsial pathogens is 100% against an unstated comparator. Can that really be right? I fear not. one of the problems with rickettsial pathogens, as demonstrated by Sabine Dietrich, who is now at FIND and used to work with us in Laos, is the low bacterial load of both Rickettsia typhi and scrub typhus, or Orientia zuzugamushi. And this will inevitably lead to the low sensitivity of PCR assays. Therefore, at the moment, we use both serology and molecular diagnostic techniques in combination. One unanswered question that colleagues in Moro in Bangkok are now trying to investigate is, could proteomics help? In scrub typhus and murine typhus, are the protein signatures and antigen detection possibilities for diagnosing these important pathogens? I think they're especially important pathogens because they are easily, at least in theory, treatable with tetracyclines. I think it's better to be finding pathogens that are easily treatable than those that are not. Another pathogen that we see a lot of is the Japanese encephalitis virus. One of the problems with the diagnosis is that PCR for JEV in both serum and CSF is usually negative by the time patients present. Only roughly 3 or 4% of patients presenting with CNS disease are PCR positive on CSF. And so the diagnosis has come to rely on detection of anti-JEV IgM in CSF and serum. But Audrey Dubois-Perez from Marseille, who's our head of virology in Laos, has been looking at the use of this diagnostic tool, and it seems that it has relatively low specificity, and that in Laos at least quite a lot of patients with anti-JEV IgM in CSF have other diagnoses by direct tests such as PCR and culture. So again, could CSF proteomics, looking at both the host responses and could there be a specific JEV protein in CSF akin to dengue NS1 that could be used for diagnosis? And colleagues in the Department of Biochemistry in Oxford are looking for that at the moment, in the hope that this may allow an improvement in JEV diagnostics. And this, I think, is especially important at the moment in view of what's been happening in India. As many of you will have seen on ProMed, many reports of Japanese encephalitis virus CNS disease in northern India over the last decade, enormous seasonal epidemics. But again, it's been only diagnosed by ELISA for anti-JEV IgM. And Indian colleagues working in Gorakhpur have wondered whether this really is caused by Japanese encephalitis virus, and whether it is not that, and a large proportion of the patients are really with scrub typhus. So there's been increasing realization that scrub typhus is an important cause of CNS disease in rural Asia. And it's a terribly important distinction to make because JEV is basically untreatable at the moment and leads to terrible sequelae in a minority of patients, whereas scrub typhus also has a significant mortality but is, in theory, readily treatable with tetracyclines, which are inexpensive. So therefore, I think there's a lot of importance in trying to tease this out, and how much of these large seasonal epidemics are due to scrub typhus and not JEV. Another problem that we encountered was mixed infections. There are many reports of mixed infections in the literature, but they're often, not always, but often based on dual seropositivity. Are these true mixed concurrent infections? Are they both causing disease? Or are they sequential infections with antibody persistence? Or are they assay cross-reactions? Or are they non-specific antibody responses? So Dr. Kukeo Apomasan, who's also here, we worked together to propose a grading system for mixed infections to try and indicate the the strength of evidence that they really are mixed, with a grade 1 mixed infection based on culture and or molecular detection of both pathogens, and grade 3 just based on serological diagnosis using admission serology. So I think we can only really be confident that mixed infections really are mixed, are grade 1. But having said that, for common diseases, especially with common routes of transmission and common risk factors, we obviously would expect mixed infections, but which are really mixed and which are not mixed. Working with Find and others 6-7 years ago, started to look at the gaps in the literature, and the team put together these maps of, on the left for Japanese encephalitis virus and on the right for typhoid, and where these pathogens had been described for in mainland Southeast Asia. And I was really surprised at how few places these actually have been described. And as you will see, they're not all, but largely focused around large urban centers, and mostly to do with university and institute research groups. So there are enormous gaps in our knowledge about where these pathogens are. This will not be the whole story, because ministries of health and others will have additional information that will not be publicly accessible for maps such as these. But I think this has these large gaps of terra incognita have large ramifications for our understanding of the epidemiology of these important pathogens, and also for the now a lot of current interest in niche mapping to try and understand where pathogens are and where they may be. With poor quality epidemiological data with a poor geographical spread, it will make niche mapping much harder. So taking this forward, a consortium of different organizations have developed a mapping system for the distribution of different etiologies of fever in Southeast Asia, South Asia, Africa, and South America. And this work will hopefully be out in the next few months. But on a smaller scale, this is Lo Nam Tar is in northern Laos, Salavar is in southern Laos. And these are maps of the homes of patients who came to the provincial hospital where the study I mentioned, headed by Maifong Maisai earlier, where they came from. And if you look at the maps, you can see that, hopefully, that there are many of the patients' villages where patients came to hospital are in long lines, and that's along roads. Are roads a risk factor for acquiring disease? Probably not. But on those maps, the crosses, not the dots, but the crosses are the villages of patients who nobody came to the hospital with fever in our large study. And you can see that there are very large areas of these provinces where nobody came with fever. So it seems that access to healthcare is an important determinant. It seems unlikely that the people living in villages denoted by a cross far from roads did not have fever, but it means that there are many communities without access to diagnostics within those provinces. It also means that we'll be getting the story that we're acquiring about the epidemiology of fevers within these areas will by definition be wrong, because we're only sampling a relatively small proportion of the population within those provinces. There are enormous areas of tropical Southeast Asia, from Nepal going through Northeast India, northern Myanmar, northern Vietnam, Laos, southern China, where there's very, very little information about the epidemiology of fever. And it's in political terms, it's called Zomia, Z-O-M-I-A. And that area is the largest area of 100 million people with very little information about infectious disease epidemiology. We were discussing in London a few weeks ago for a study that I'll come on to shortly, about should we, in a large multi-center study including Africa, should we look for Japanese encephalitis virus in Africa? We thought probably not, it's never been described there. But then we did a PubMed search and found a recent paper in the New England Journal that appears to demonstrate Japanese encephalitis virus in Angola. So this was really very unexpected and has led the team now to seriously consider looking for Japanese encephalitis virus in the African study sites. But this is analogous to an extraordinary event in the scrub typhus world recently, where scrub typhus was clearly demonstrated in South America. And there are also some evidence of it but only serological from Kenya. And there's a new related species, Orient Chuto, discovered in Dubai. So the scrub typhus occurs in the red bordered area, which is called usually in the textbooks the triangle. It's not a triangle, it's I think a rhomboid. But you can see that until recently, the only records of scrub typhus were in that red bordered area. But now we have very, very good evidence for it on an island off southern Chile, for a related new species in Dubai, and some serological evidence of it in Africa. And this has rather shaken the scrub typhus world, and it's still unclear, is it elsewhere in South America, or is it just in southern Chile? But how did it get there? So it's the importance of keeping an open mind about the distribution of pathogens. I think the scrub typhus and Japanese encephalitis virus examples just illustrate how little we really know. Another, I think, interesting issue is how many pathogens are there? There have been various studies using mathematical modeling, using discovery curves to try and determine how many species of tree are there in the world. If you plot on the x-axis time and on the y-axis the number of tree species discovered, you can use mathematical modeling to try and estimate how many tree species there are in the world and how many remain to be discovered. The group of pathogens that this has been mostly done with so far are human viruses, and as the x-axis on this is year, it's missing. But as you can see, there's been an enormous surge in the description of human viruses, which is perhaps gradually slowing off. And interestingly, if you compare arbovirus with non-arboviruses, the number of non-arboviruses discovered per year recently has declined dramatically. Whereas non-arbovirus, it's continuing to go up. So we applied these techniques with mathematical modelers to try and understand how many human pathogens there may be in Laos. This was led by Madeleine Clarkson as a part of her London School MSc student. And we used modeling that I don't understand, please don't ask me about it, but to try and estimate from the historical record of when pathogens were described in Laos to how many may we have left to describe. Currently 148 pathogens have been identified by forms of direct identification. But Madeleine's work showed that there's still a steep climb so grade 1 is direct detection. So you can see from going back to the 1880s, a gradual increase in the number of pathogens described in Laos. But there's been a big surge in the last 15, 20 years, with another surge during the 1930s and then in the 1960s. Madeline used this to try, using this Markov chain Bayesian modeling, to try and predict how many pathogens that there may be in Laos. And this is the provisional graph from that, suggests that at the moment, ignoring future immigration of pathogens into Laos, that we have about 158 pathogens within the country. So it's suggesting there are about 10 more to find. So that has implications, because therefore, should we be devoting more time to pathogen discovery? Perhaps not. Maybe the best thing is us to look for new pathogens coming into Laos, but to concentrate on trying to optimize the diagnosis and management of those that are already there. If, say, the modeling showed that there were 1,000 probable pathogens in Laos, then I think that would be a very different story. And should there be one empirical treatment policy for a small country? Laos is a very long and thin, and Professor Lisa White in Bangkok worked on trying to, from an idea by Nick Day, to try and model the disease heterogeneity that we were already aware of in Laos, and try and see whether one algorithm would be appropriate. From the fever study we did in northern southern Laos, you can see that there are quite large differences in the optimum antibiotic for the different pathogens that we described. Within the south, doxycycline probably superior to azithromycin, and because there's a lot more malaria in the south than the north, coartem more in the south. So this raises the issue of, even in small countries, is one algorithm the best way forward, or do we need to have a north-south algorithm? So therapy, many of the pathogens that we see, there's really critical evidence about how to treat them. One of those is murine typhus, that there's never been a clinical trial to try and understand the optimum treatment, which I think is rather extraordinary considering it's a global disease. It's a neglected disease, and as Daniel Paris would say, it's too neglected to be on the neglected disease list. And so we did a clinical trial comparing doxycycline 7 days with doxycycline 3 days with azithromycin 3 days, to try and understand what is the optimum treatment of uncomplicated murine typhus. The primary outcome was treatment failure with a fever at 72 hours, plus the patient still being clinically unwell. This was performed in Vientiane. We were surprised and concerned to find that the number of treatment failures was very significantly higher in the azithromycin group than in either of the doxycycline groups, as you can see here. And this is the Kaplan-Meier plot. The upper green line is the azithromycin, and the doxycycline 7 days and 3 days are the two interlinked lines below. And you can see that for those, for patients with murine typhus, the fever clearance is inferior with azithromycin than with the two doxycycline doses that appear to be roughly equivalent. Therefore, this suggests that at least in Lao adults, for the management of murine typhus, we should not be using azithromycin. But this has, again, I think, major ramifications in mainland Southeast Asia, because this is often used for treating murine typhus in pregnancy. And work by Rose McCready and others on the Thai-Myanmar border and Villa de Chansamuth in Laos have demonstrated that murine typhus is a major cause of fever in pregnancy with negative outcomes. And also in young children, there's still controversy about the use of doxycycline in young children, but we were hoping that azithromycin would be a way forward. But for murine typhus, this evidence suggests not. When we planned this study, we had missed this paper on Brillzinser disease. Brillzinser disease is the recurrence of the relapse of epidemic typhus, Rickettsial prausachii. And there was this case report of some patients who failed azithromycin treatment in Brillzinser disease. that normally responds very quickly just to one dose of doxycycline. And Rickettsial prawazacii and Rickettsial typhi are very closely related. So suggesting that there might be, say, a 23S RNA determinant of intrinsic azithromycin resistance in both Rickettsial prawazacii and Rickettsial typhi. And that's being investigated at the moment. But I think we need to reconsider the use of azithromycin in murine typhus. But what do we do about pregnancy? I think that still remains unclear. So I'd like to conclude with mentioning the FEBRA study. That's a large multi-center study in 5 countries that has been designed to try and answer some of these questions on the epidemiology of fever. It's led by Professor David Mabey from the London School, and it involves sites in Laos, Malawi, Mozambique, Myanmar, and Zimbabwe. And the idea is to try and use consensus protocol with common diagnostics to try and get around the issue that we have had great difficulty in comparing between sites because of different inclusion criteria, different diagnostics. And all the diagnostics, apart from blood cultures and point-of-care tests, will be done at reference laboratories at one place to try and stop the influence of variability between laboratories, and to try and at least to have for those countries comparable information that could inform knowledge about etiology and about how to generate algorithms in these countries. So these are the study sites. Thank you very much.